Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Everybody, welcome to Melanoma Matters. I'm James Larkin. So today we're going to be talking a little bit about the ADAPT-IT study from Mike Poster and colleagues, which was in the JCO a couple of years ago now, although there's an update as well, I think, in CCR in the last little while. An interesting idea, interesting strategy. So there's some things to talk about there. But before we do that, Sapna, icebreaker question. So the obvious one is, tell us about the artwork on the wall behind you.
I don't know anything about it. I'm down in New Orleans for SMR. New Orleans is home to, it sits on the Gulf of Mexico, so home to incredible oysters. The famous barbecued oyster. They have Cajun oysters down here. We're going to do an oyster happy hour tomorrow, I hope. Oyster Bloody Mary shooters, So we think these are Gulf oysters. They're kind of actually small because Gulf oysters are usually rounder. But that's what I think we're looking at.
Yeah. Wow. Okay, that's cool. So SMR New Orleans, October 24, just as the big storm's about to hit Florida. Yeah. So let's wait and see what happens, I guess. Okay, so into this paper, do you want to maybe sort of say the background, maybe the citation, stuff like that, and we can talk a little bit about what they've shown?
Yeah, I think you need to give Lisa like a throat lozenge or something too. Okay, so ADAPT-IT study, adaptive dosing of Nivo-IPI immunotherapy based upon early, interim radiographic assessment in advanced melanoma. Mike Postel, first author, Paul Chapman, senior author, Jed Wolchuk, penultimate author, and this was in JCO 2021. And I have to say, this is a study. So we chatted with Jed, and Jed told us, one of the things he did early on was, as Ipi-Nivo was kind of making its way forward, they were interested in alternate dosing and things. And he gave his trainees, Maggie Callahan, Arvin Yang, and Mike Postow at the time, like a heavy touch on all of these projects, which is really incredible. So, BMS knew Mike to be a really great longstanding investigator. Obviously had that Sentinel New England Journal report on abscopal effect many years ago. And so, the real question that Jed alluded to there, but that's a real world question is, of course, we know Ipi-Nivo, checkmate 067 dosing is 4 induction doses and maintenance Nivo. But if somebody's responding, must you take all 4 doses? And might you generate a response to 1 dose or less? This study was 2 doses, so they reference, of course, reports of a single dose generating response. So they basically did an open label, single arm, we would call it a phase 2, certainly, where they gave the standard dose of Nivo-IPI. And then basically every 2 cycles, correct me if you understood it differently, every 2 cycles they assessed for RECIST fate. Favorable anti-tumor effect is what they called it. That's kind of a cute term they created, fate. So RECIST fate. And if you had RECIST fate, favorable anti-tumor efficacy, basically roughly defined as reduction of any percentage of your tumor burden, or it would be stable disease up to about 4% growth of your maybe target lesion. But the bottom line is, if you just, they're going off of what we do in clinic, which I think was really lovely. We are charged with this in SWOG all the time. You can apply all these fancy criteria, but how do people treat patients in the real world? Well, what happens is they come to your clinic, you give them treatment. Absent toxicity, you just ask, is their cancer better, worse, or the same? And if it's better, you're on the right track. If it's worse, you have a moment to contemplate. And if it's the same, you sort of think, well, the same is certainly not worse. And so they're sort of capturing that in FATE, which is, look, favorable might be some decrease, which technically qualifies as stable disease because it hasn't hit RECIST response yet, or growth that's under this, 5% kind of error, measurement error. So any 4% or so growth, again, stable disease, you would clinically say this is the same. This is the same cancer. Or that's within that margin of error. This is the same cancer as that I started with. So you would keep going, is what I'm trying to say. Or you would say something favorable has happened. So if somebody had a favorable response or favorable anti-tumor effect, they basically stopped and moved them on to maintenance. If they had a non-FATE, so they did not have favorable, they took 2 more cycles and reassessed with the primary endpoint of week 12.
Yeah, I think this was nice. And one of the nice things for me is the fact that it does feel a little bit like how we practice in clinic. And also, before we get to the results, the impression that one often has, I think, when treatment's working before you do any scans, when you maybe see the patient that, for the second cycle or the third cycle, I think most patients, certainly all symptomatic patients, I have quite a clear sense just from talking to the patient whether it feels like there's any benefit from treatment or not. But of course, what we've tended to do is to wait to 12 weeks to do the scans. But I think most of the time when you do the scans, you'll have got a pretty good clinical intuition already by then, whether the treatment's helping or not. And of course, if you don't think the treatment's helping, if people are getting obviously worse, you would do early scans to think about other treatment options. So, I like that component of this.
Yeah, I guess I will pick up on 2 things there. I mean, you remember early in our Metarex ipilimumab days, those protocols scanned after 2 cycles. So it was a 6-week scan. That was pretty routine with a lot of the IPI. And the reason we leaned away from that was this idea that on IPI, you had pseudo progression. So we were making too many false decisions at week 6. This was because we were coming from dacarbazine, temozolomide biochemotherapy experience, where if somebody's progressing at 6 weeks on high dose IL-2, you didn't keep going. You didn't give them more, or 2 cycles of however you timed it. If somebody's progressing on 2 cycles of biochemotherapy, how did you justify the next? Because there was no late catch-up effect with those therapies, mostly heavy cytotoxic therapies. But with the slower immune system, you obviously can get progression before you get response. There was this question was it just tumor flare from infiltrating T cells? I feel like that's really not been borne out well, though maybe we should ask Tony about that, because I do think he has some feelings about this. I'm not sure I'm familiar entirely with data that shows it's T cells infiltrating that leads to tumor swell. It might just be tumor growing before the T cells have a chance to get there and catch up. Anyway, so pseudoprogression moved us away from wanting to do 6-week scans, because early on it does seem like we were pulling patients off early. And these authors allude to that to avoid, pulling off people who had non-FATE, you gave them more treatment. But then we got a hold of these PD-1, anti-PD-1 agents, and then certainly put them in combination, where pseudoprogression is exceedingly rare. We talked about it actually on our very early episode. I'm not even remembering which one, but it was one of our very first fact checks we did, where we said, what is the rate of pseudoprogression? And I looked it up, and it was the WHO series that basically describes it somewhere in the range of about 15% for IPI, but it's really low for single agent PD-1. It's like single digits low, and with the combination even lower. So we don't have to worry about pseudoprogression. This goes back to, could you do a 6-week scan to make decisions? Yeah, maybe with these therapies you could. With IPI alone, maybe you would not want to. So this idea of doing a scan at 6 weeks is really nice. But if clinically you're not doing that, if you're waiting till 12 weeks, the other thing I wanted to pick up on is, like you said, you will often get a sense based on tolerability about a potential anti-tumor effect. But it's not two-way, because if a patient is swimming through treatment beautifully, 0 side effects, I'm not sure I have an instinct about what that scan is going to show. Many times that scan has shown a response, but I've been equally surprised where I think that scan is going to show a response. The patient's healthy and sailing through this treatment, and the cancer's getting worse. Do you have a clinical instinct when they're not having side effects?
No, I mean, and I think my earlier comments were specifically about people who are symptomatic at the
Yeah.
start, basically. I think for people who are asymptomatic, I mean, I'm not sure how you would know.
Yeah.
How could you? But yeah, no, I think those were all nice points. So then, how about the results? If we said,
Yeah. And
go on.
actually, one of the things you've taught me as we've been chatting these last few months really is my radar goes up a little bit more with the LDH, honestly. So like they might be feeling well, but I am paying attention to that LDH. And so if they're coming into treatment with a high LDH, I am very cautious that this treatment might be enough, combination treatment. But if they are walking in with a normal LDH and asymptomatic and tolerating treatment well, I just try to certainly feel more optimistic about it. Anyway, so the results of this primary endpoint was RECIST response at week 12. Recognizing they take a look at week 6 for fate, non-fate, and then if you're responding, you could be a clinical responder there, and then you would stop your ipi-nivo and just go on to maintenance. But the endpoint is actually at week 12. So what they saw was 68% of patients had a favorable anti-tumor efficacy or effect. So RECIST fate at week 6. So 68%, 2/3 of the, by the way, a small study, 41 patients, but still 2/3 had basically met the criteria for taking only 2 doses of nivo-ipi and going on to maintenance. And then at week 12, 48% had a RECIST response. And I think in my mind, that really matches up with Checkmate 067. This 48 at week 12, by the way, it's just at week 12, measures up really nicely to the Checkmate 067. And here at any time, 58% end up having a response. So 48% at week 12, but that's to say there's another 10% who go on to have a response. I think that 10% is fascinating. So let me toss it to you and see what you think.
Yeah, all agreed. I mean, the other thing I was just going to mention actually is the number of mucosal patients. I'm going to cough. Hang on. We're not getting vaccinated against COVID here. Yeah, so if you look, it's like about 20-25% of these patients are mucosal. And they comment on that as well. And then the other thing is actually some of these patients had pre-treatment as well, not many, but there was a little bit, tiny amount really, of prior anti-PD-1. So that's all really to say that seeing that level of efficacy in this group of patients is really, I would say, quite impressive. And without kind of wanting to get into the Checkmate 67 stuff again, yes, this is a relatively small number of patients, but to me, one of the things this is speaking to, that this is a group of patients who've been treated at a centre that really knows what they're doing with using these drugs. They'll have been exceptionally well treated. It's a small study. You know, one of the problems with phase 3 studies is that lots of different centres, maybe some of them have got less experience of really trying to get the most out of the drug. So I think it's a strong level of benefit here, I would say. You're smiling at me though.
Yeah, well, because you said we're not getting vaccinated against COVID, which is like a stop the press moment. It's because you don't have access to the new vaccine, not because you have some philosophical disagreement.
No. Well, just to pick that up, no, it's clearly not. I mean, I'd have it straight away if I could. But yeah, I think the national guidance in this country, which is what we go by, is that healthcare workers aren't being immunised against COVID, period, as you would say, this autumn and winter. So I guess that's where we are, but it just feels a little bit like there's more COVID going around, and so we're going to get it. And obviously we hope our patients have all been vaccinated and all protected, but the reality is going to be that they aren't actually going to be all vaccinated and protected, and some of them are quite heavily immunosuppressed. Sorry.
Was there an argument that natural immunity is going to be stronger than vaccination immunity?
I think it's complicated, different strains, all that sort of stuff. I'm not sure, but at the end of the day, I mean, in this country, I'm sure everywhere else, there's a expert committee have looked at all of these things, and obviously vulnerable people are being immunised, but healthcare workers aren't being immunised, as I understand it anyway.
Totally unrelated. I mean, I told you the ad campaign in this country is get your together, and it's getting your flu shot and your COVID shot together.
Yeah. Well, no, I already have my flu. I think I told you the other day, so I'm good for that. But not COVID. Go on.
So about this, back to this paper. So, I'm curious so at MD Anderson, we fell in love with this paper. I mean, we loved it. First of all, we kind of like a phase 2 as well. We love a phase
Did you look at figure one though on this one or not before you fell in love?
2. Stop.
I'm only kidding. And I'm not saying that figure one in this paper is like, it's just when we talked about something the other day. What was that?
I know,
And,
you
and you
caught
said
me.
you hadn't looked at figure one, but you all really loved
And
it
look
at
at the
MD Anderson.
supplemental. I hadn't looked at the supplemental. Look, figure one is a swimmer's high. You caught me off guard. I was like, what was so controversial about figure one? Figure one is fine, everybody. It's worth looking at. There's
That,
nothing wrong with figure
that wasn't a specific comment about this figure one. It was just about the whole idea of
yeah.
of looking at
Table
figure
one,
one.
figure one, supplementals, everybody. We know.
Yeah. So listen. So what about the MD Anderson love affair with this paper? Go on, do
Well,
tell.
first of all, we love Mike Postow. We love that whole group. And we liked this idea. How brilliant to say, is 2 cycles enough? And they did kind of a nice, really clean design. Could I extrapolate this to uveal? I think there were a few uveals in this study, one. But could you extrapolate it? It's an interesting idea. I'm certainly not in the business, sort of like we talk about with PDL1. I don't want to use something to withhold treatment. But if I have some sort of indicator that tells me I'm there, if LDH normalization tells me I can switch from BRAF targeted if I'm trying to sequence a high risk patient to now immunotherapy, great. If fate at 6 weeks tells me you probably are good to just move to Nevo, great, right? And that's what I think this paper taught me. The real question is, do you incorporate this kind of, are you allowed to incorporate this kind of data in the UK, or would you have reimbursement issues if you don't give all 4? Not because of toxicity issues, but just because you're like, good, they're doing well with 2, I don't need to give them. A, that's question A. B is, what do you make of this idea that at week 12, 48, nearly 50% of these people are having a response, but there's another 10% that get a response later? What do you make of that? That's 10% that are getting a response just with Nevo. And then, of course, we love chasing a CR as a theme here. Do you think they're moving from fate to RECIST? Are they moving from RECIST PR to CR? I mean, how much do we really know about that 10% additional?
Yeah, well, I mean, just to go back to the reimbursement, I mean, there'd be nothing to stop us deciding we didn't want to give drugs,
Okay.
if you see what I mean. So I don't think there'd be any kind of problem there. And then, in fact, it would save money, right, in a publicly funded healthcare system if you adopted that as your part of your practice. I'm not sure people are, though. You were going to say something, I think.
If you gave 2 cycles and said, I want to stop, are you able to go on to maintenance Nevo?
Yeah, there wouldn't be. I don't see that there'd be any particular problem with that. I mean, the paperwork's probably not set up to do it, but I can't really see what the issue would be. And then this extra 10%, I suppose that's the other question. I mean, that's very interesting, but I'm not sure I can really work out from this what exactly is going on there. Remembering that all these patients will have had some IPI anyway in the past. Sometimes responses take time to develop. And so then can you really say that, a response in a given situation when the patients had both IPI and Nevo, is that just the Nevo part, or is it a slow developing response as a consequence of having had the IPI before? So I don't really think that we can easily tease that out anyway. I mean, I like this as well. I have to say, and I suppose one of my take homes here is that let's say you're planning to give all 4 doses of Ipi-Nivo, which I think would be the general thing that you do, and you get to cycle 3, and you're just a little bit worried, let's say, about side effects or something else, and this happens in practice in the clinic, just not entirely confident. Well, I think this paper shows fairly clearly that most of the benefit is happening relatively early on from the treatment. And so then it sort of feels to me that actually maybe there isn't a massive imperative, in fact, to give those subsequent doses. I don't need to be saying I must give these treatments. This paper gives me confidence in that, actually. And then the obvious question, there's lots of questions, aren't there? Then, is it even the 2 doses? Could 1 dose and I'm not suggesting necessarily everyone does a trial of that, but maybe it's about having anti-CTLA-4 right at the very start. That's the important thing, and maybe one dose is enough in some people. Anyway, go on.
Yeah, so what I was going to say is figure 1, I think, gives us some clues about these patients who at week 12 were responders, or were they had even more response post week 12. So when you look at figure 12, obviously you're just looking at the patients who after week 12 changed their response to something more beneficial, either went from a PR to a CR. So you can see like maybe one of these patients, but right at week 12 actually progresses. So maybe what actually happened was at week 6, they stopped their 3-4, went on to maintenance Nivo, and then progressed. Further down, you see somebody who at week 12 went from stable disease to PR with presumably they got 2 or 4 doses, but hasn't yet progressed. So you can kind of tease out, is it PRs going to CRs? Not really. Is it SDs going to PRs? Maybe. And then the real question is, if you give 2, do you lose your durability of benefit? So when you give just 2, are you popping with progression of disease sooner? And they have a nice, figure 1 is actually quite nice because those red bars, it's specifically the red bars, are patients who are progressing after a response. So it's not just progression, right? It's progression after a response. So then that makes you wonder, was there enough combination checkpoint? Was it just a fluke, small study? Hard to say. Okay, so then the second point you made about 1 dose, Mike Posto is doing something super cool in the neoadjuvant space, like in a neo-adapted, neo-NADINA, adapted NADINA, NADINA adapt. You can see I'm trying to play with everything here. Basically 1 dose of full dose Ipi-Nivo preoperative, and then surgery. And so is a 3 milligram blockade of per kilogram blockade of CTLA-4 enough with 1 dose to match 2 doses of NADINA's 1 milligram per kilogram, so a total of 2 milligrams per kilogram? Do you get the same pathologic response benefit? So that will be really cool to see that. Again, it'll be single center, small study. But, this is kind of what institutions like MD Anderson and Memorial Sloan Kettering were really known for, were these really kind of innovative ideas. They have a really nice relationship with industry, so there's trust that they can do it well and look for a signal or look for some benefit. And of course, as you mentioned, the follow-up then was published in CCR. And what about that paper? What did they show in that paper that maybe got them in CCR?
Yeah, that was the correlative stuff, I think, in a nutshell. So they did cytokines, and they did some ctDNA analysis as well, and they had more mature follow-up, obviously, by definition. I'm just looking at figure 1 now in that paper: duration of response, PFS, OS. So I think the clinical efficacy endpoints with further follow-up are still sort of standing up in comparison, for example, with Checkmate 67. I think they also had a few more patients by the time that they did this. Honestly, the correlative stuff was interesting, I think, but is anything really jumping out to me there that you think, well, that's something that we can use in clinic at the moment? I'm not so sure about this. The ctDNA stuff, for example, Jed mentioned this the other day. It seemed to track with benefit and disease bulk, which I think is what I'm taking away from the literature as it stands at the moment. And it might be that in the future, as he sort of said, that does, if you like, become ready for prime time, if you can define the thresholds and that kind of thing for how you might alter your treatment, maybe intensify. That's a very interesting idea, isn't it? That you could use ctDNA for treatment intensification or de-intensification. I actually think we'll probably get there before too long, but at the moment, you wouldn't want to use that. The IL-6 stuff, so high baseline IL-6 associated with short PFS. There's been a fair amount of work on that already. For me, that's a correlation. And there's a bit of work out there, to say the least, about actually trying to manipulate this therapeutically. But I think the jury's still out a little bit on that. in terms of whether it's something we can target to either improve efficacy or improve safety profiles. So, it's important to have done the correlative work, but it's not really changing much, honestly, how I think about this actually at the moment.
Good. Anything else to say? I mean, we didn't really see anything. Should we say something about tox? I mean, that's really part of the crux here is, can you get similar efficacy and spare toxicity with less doses?
Yeah, I mean, again, I'm not sure that there's, I'm just looking now at, this is table 3. So you've got 41 patients with FATE, 19 with non-FATE. So that's a 2/3, 1/3 split. And then you look down those columns. So, for example, transaminitis, clearly a lot less. This is grade 3 to 5 in the FATE group. So sort of around about 15% in comparison with 35%. Actually, it looks like there was the diarrhea. There was a bit more grade 3 to 5 in FATE than there was in non-FATE. Caution with small numbers as ever. Anything else really jumping out? Go on.
Okay. Sorry, I guess you're looking at it with a different way than I did, which I like. That's, again, good why we do this. So I looked at just the all patients because I'm just wondering, again, knowing that 2/3 of the patients basically did stop at week 6 with combination. But, are we having in general a lesser rate of high tox than maybe what you saw in 067? We know the 047 numbers off the top of our head. Is it fair? What do you typically quote people for grade 3 to 4? For 067?
Yeah, well, I mean, I would normally quote in excess of 40%, and actually, if anything, in practice, it may even be a little bit higher than that.
Yeah.
So, if you look at the actual numbers, it may even be 50, 60%. I mean, I must say that I find the most helpful thing to quote for patients is treatment discontinuation as a consequence of side effects, because it kind of brings everything together. And I would quote that at 30, 40% for standard dosing of Ipilimumab.
I agree with you, with the caveat that it really does depend where these trials or these things are done, because same with our high dose IL-2 days and our biochemotherapy days, a less confident center will discontinue for something that a confident center would say, I'm going to treat through this, mild hypotension or a mild cytokine release back in those days. In these days, like I've seen people discontinue for rash that many times, like I need to see what rash caused you to discontinue your life-saving therapy, but I get that happens. So I guess my point is I looked at that all patients and I see a grade 3 to 5 of 56.7% treatment related. And I think, that's actually pretty similar to 067. So then again, if the efficacy is coming with the early doses, is the tox also maybe just coming with those early doses? Too small to really say for sure. I don't see discontinuation on here, but of course, tell me if you see it. Interestingly, I see that you took it as, what is the difference in FATE and non-FATE as far as these? And you pointed out stuff it didn't catch my attention, but like, more LFT elevation in the non-faders, more diarrhea in the faders. So that's kind of an interesting take. We would never, use that to assess somebody's likelihood of response or non-response, but it is an interesting observation that you had more LFTs.
Yeah, I mean, part of the thing, just to talk a bit more about this, maybe on table 3, is diarrhea and colitis are listed separately and not close to each other. So if you scroll down to colitis, which is about the 6th or 7th row from the bottom, it's kind of 10% in FATE, 5% in non-FATE, and then you go back up to diarrhea, and then you kind of add up the numbers together. So then you've got sort of early 20s for FATE, grade 3 to 5 diarrhea and colitis. And actually only probably around about 10% for non-FATE. And, it's like being on an IDMC, isn't it? You look at these tables and you think, could this be a real difference or not? But that transaminitis, that's, I'd say, grade 3 to 5. That's a fairly striking looking difference. But because of the small numbers, I guess you need to just suspend judgment, really, don't you?
Well, and a podcast we have yet to do that we will, because I think it gets to this is, look, these immune adverse events are likely to come in our hands when we use these treatments, but what is our reflex to that? Is our reflex 2 milligrams per kilogram of steroids? Is it light touch steroids? For me with LFTs, I think I said this to you before, my teaching point is always, I just ask the person, do you know what the LFTs were last week? Not before you gave them the last treatment, but last week. Do you know if these LFTs are uptrending or downtrending? You just have a snapshot that looks scary, but perhaps these are even better than they were last week. So maybe just take a beat, check it again in 48, 72 hours, and then look at the trend. 2 data points is a trend, right?
Yeah, absolutely.
And then
No question at all.
so it's nice to know in these kinds of things also, like, what was the management of these, and, you know, et cetera, et cetera. We'll get there, because I think we have a podcast or many to record about IRAEs and management and light touch steroids and the meta-analyses that have been done on this kind of stuff. So.
Yeah, I just got a message saying that NADINA is now reimbursed in the Netherlands. So there's a good piece of news to finish on. Whether that's in the public domain or not, I don't know, but fantastic. That's wonderful news, isn't it?
Get a lot of this private like this, a lot of private for James Only Eyes news.
Well, I can't tell you who sent it to me, can I? It's not Christian Black, actually, just so we're clear, someone else. Anyway, let's pick up another time, eh?
All right. Thanks for this good chat.
Yeah.
Well done, Memorial, Mike, and colleagues.
Good job. Okay.
Thanks.